Thank you. Dr. Hickman took a bit of the wind out of my sails because I'm going to speak about a few things, the same things, but not exactly the same. I'm not European either, but I'm a little closer to Europe, coming from Cape Breton, Nova Scotia. I'm here to talk about harm reduction and the HCV prevention and care continuum. It's something that I'm very interested in. I'm trained in addiction medicine. I work at the HIV service at the McGill University Health Center and also at the Public Health Department, so kind of makes sense. A lot of the key references come from the International Journal of Drug Policy that I use for this talk. So I wanted to talk a little bit about people who use injection drugs. I'm not going to make any apologies. It's a very important group, and coming from the field of addiction medicine, I think we always have to advocate Hep C in this population and harm reduction. A little bit about the promise of TASP. When I think about promise, I think about broadly the promise and what that might do for care for this population. Integrating harm reduction, prevention in the HCV care continuum, and a lot of us talk about the care continuum. And I specifically want to talk about the preventing HCV infection as the primary prevention, HCV care cascade where care is offered, and then preventing HCV reinfection. So as we've heard a lot of this already, high prevalence levels in this population. We expect fairly, 29 to 30 years before people get to F3 levels of fibrosis. We have, regarding some substances in the natural history of hepatitis C, there doesn't seem to be a lot of concerns around those substances, but alcohol for sure is very important. Again, though, research done on substances that are illicit in this population and what it actually does to people and their health is not that common either. And it's an important cause of death in this population and harm. So I want to bring back to the reality of people who inject. This is a disease. I refer to it as a disease. Some people have trouble with that. NIDA refers to it as a chronic relapsing brain disease. There's lots of comorbidity, mental health problems, the poor social determinants of health. When we think about care, we're thinking about and progress in care. It's not linear or cumulative. It tends to be iterative. You start, you stop, you go back, you figure things out. There are limited medical therapies. We talk about medicine-assisted treatments for addiction. Very, very limited. We have opioid substitution therapy, very, very good, but we don't have much for the stimulants. We need work there. And then we look at chronic care over the long term. This is what we need. We need a chronic care, a chronic disease lens, and that includes relapse prevention. I've worked in methadone for over 15 years, and some people succeed in finishing a methadone treatment, but as soon as they walk out the door and we never hear from them again. It's a very strange thing in that we've not done much to keep in contact and ensure relapse prevention can occur. So the idea of HCV care for me is through a chronic care lens and thinking about addiction always. We talked about the people that had a lifetime history of injection, and then the people who are current injectors, and then people who are using opioids and can take advantage of opioid substitution therapy, and that represents this large group. But again, I bring up the social determinants of health for the current injectors, and you've seen some of that earlier. Less income, education, employment, comorbidities, health services are not adapted or appropriate, and providers are not trained, lots of stigma and social exclusion, and poor housing and food insecurity. So just to revisit harm reduction, what it is, it's any policy program that's designed to reduce drug-related harm without requiring cessation of drug use. It's that simple. And it can be directed towards the individual, the family, the community, or society. And I think it's something for us to continue to remember as we think about things like TASP and going forward and trying to scale up treatment for this population. So what we also recognize is many of the harm reduction programs and policies are focused on the users that are experiencing the greatest harm right now, so the people that are currently injecting. And that's where you see making sure there's greater access to services and safer ways to use, needle and syringe programs, availability of other equipment for injection, opioid substitution therapy. But the reality is that harm reduction can be applied to all levels and all stages of use, and we can't forget that. And in some ways, you can stop the problem before it happens if you think in the long term, if you think along that continuum. WHO, UNAIDS, they've come up with a comprehensive package of services for people who inject. You see, a lot of people recognize these services: needle syringe exchange programs, or needle and syringe programs, or material distribution programs, opioid substitution, testing for HIV, ARVs, prevention and treatment for STIs, also looking at condoms, targeted information, and prevention, diagnosis, and treatment for hepatitis and TB. Harm reduction broadly for people who inject, there's a list here. This is coming from the BC Centre. A really nice list of what is considered evidence-based. These are things that can be used in trying to package any care program for this population. I added community-based naloxone, which is the evidence-base is not there yet, but it's being developed. But again, is a little bit related to early warning signs. When we talk about people coming in contact with illicit substances on the street, we had an outbreak of basically an epidemic of overdose deaths in Montreal last year. And essentially, if you treated it like an infectious disease, you'd have a case fatality rate of 25%. And that is striking. And so this is happening all the time. So the promise of TASP, when I say TASP plus, the idea here is, as has been mentioned, is we're talking about treatment scale up for this population, and it's a combination prevention strategy. We're looking at interventions along the continuum to offer care, and a parallel expansion of harm reduction prevention interventions to ensure uptake of care and a sustainable cure. I often talk about the goal here of being cure in the population and resulting in less community HCV incidence and prevalence and less patient-related morbidity and mortality. And this will, I think, the plus as well as part of advancing care for people who inject overall. I'm not going to go into great detail, but we did a task modeling as well in Montreal with the injecting population with Anthony Cousin, who was a postdoc from France. And we come up with very similar things that Dr. Hickman spoke about. The fact that, and I want to call your attention to scenario 7, and this is a situation where we affect a lot of the care cascade. We leave harm reduction, we leave it stable, that's understood to continue. But what we've done is we decrease the time to detection of Hep C to 6 months, the linkage to care to 6 months. We get 90% adherence to the treatment. These are using DAAs. And we get a treatment initiation at 20% per year, which is very high. But you can see what happens to incidence over 10 years in the top left corner. It goes from 10% to 5%. And then per 100-person years. If you go to prevalence, we get a really large decrease from about 55% to just over 20. And then you do see also the improvements in the decrease in complications over 10 years and 40 years. The interesting thing when we do a scenario 8, which is where we, that 7 basically is treatment at any stage of fibrosis. But we go to scenario 8, we're looking at only treating at F2 to F4. And you can see what we end up doing is, yes, we can change the course of the disease for people, but what we don't do is we don't affect the motor of the disease, of this epidemic, which is we maintain our incidence quite high and our prevalence. So this is one of the, as mentioned, is very important as far as trying to prevent the ongoing epidemic of hepatitis C in this population. The Continuum, many of you have seen this, largely inspired by some of the work in HIV. So living with HIV, getting diagnosed, linked to care, evaluated for your liver disease, treatment, and then a cure. Want to add the idea of prevention to this and public health and looking at primary, secondary, and tertiary prevention. The idea here is that there's this group of people that are at risk and don't have hepatitis C, and Dr. Hickman spoke about that. I'll mention them briefly. The idea here is preserving health before people get hepatitis C or other infectious diseases. Then we transition to secondary and tertiary prevention, which is about stabilizing health and reestablishing health. And the idea here is to screen, diagnose, get people into care, treat them, and then cure them. I separate cure because I think that's another phase in the continuum that we need to really spend a lot of time on. Again, Dr. Hickman has mentioned this, and the idea is that primary prevention of Hep C for this population works. The timing is crucial. You need to do this in new injectors that are the most at risk. Needle syringe programs, opioid substitution, behavioral and counseling interventions, etc. Hagen did a systematic review basically showing the same thing, a 75% decrease in incidence if using multi-component interventions that involve people stopping or eliminating injection or at least using safely, also using and behavior change counseling, and also using opioid substitution therapy in many cases. There's good evidence. This is the Turner paper that Dr. Hickman referred to. Again, basically really good evidence that these programs work, and we have to remember to continue to think about them as our go-to as we go forward with the idea of TASP. So now turning to secondary and tertiary prevention, the idea of the real care cascade, the stuff that's happening in the clinic. There's some evidence about how to enhance testing, linkage of care and treatment in this population. There's a nice review in the International Journal of Drug Policy from Meyer and colleagues that tries to break down the various specific interventions that happen across the care continuum. And so looking at how you diagnose Hep C and get people into care, and then when you start treatment. So I encourage you to look at that because it really is a nice review. What we can say about enhanced testing initiatives, there seems to be some good evidence for using dry blood spots. We use them in surveillance all the time for some of the vulnerable populations. We just take a finger prick, put it on paper, and get it analyzed. It shows that it's quite helpful in getting people uptake of testing in this population. But no evidence yet for point-of-care testing, and that's just to be developed, I think. Linkage to care, randomized trial of, again, these care linkages and care where it's being offered often happens in the settings of community-based clinics like L'Actuel and other places where there's already a focus on addiction care. So here, this is a randomized trial looking at care coordination and methadone maintenance treatment, where they use a fairly intensive intervention, behavioral intervention, care coordination with motivational interviewing, education, and case management, and are 4 times more likely to have an HCV assessment. Some people have talking about using the FibroScan to engage people in care and how that might work in a community, for example, to get people thinking about hepatitis C and possibly get targeted for care and triage for treatment. And then we look at HCV treatment. We know that treatments are safe or relatively safe. There's limited data on the novel DAAs. We're starting to see that in this population. But we can also see that this is a trial that came from in American Journal of Gastroenterology, looking at patients deferred from hepatitis C treatment because of substance use disorders or psychiatric problems. And they were offered integrated care involving a hepatologist and a psychologist delivered behavioral intervention, and they were more likely to initiate treatment within 9 months. So I'm putting these up to give you some ideas, some of the promise, some of the things that we could consider. A nice review by Bergman and colleagues looking at models of care where there's multiple components, basically suggesting that primary care is a great place for this to happen, and that when we integrate hepatitis C care in the primary addiction care or primary care general practices, we find it to be quite effective and useful. The problem is many of these models have not been directly compared, and there needs to be work done in this area. So going now to the last phase, which is the idea of the cured part of this and the reinfection, and we can make the argument that, again, we return to the primary prevention approach. But when we think about care post-cure, Dr. Huchet mentioned it, Dr. Hickman mentioned it, the idea is that we want to be able to, we can't stop the care for hepatitis C after the cure. Otherwise, we will have things like reinfection and other problems. Reinfection rates are being determined as we speak. Protective immunity has been proposed. But there's not a lot of work in this part of the care cascade that has been published or studied, where there's been studies and published, and this is why it's not included in the Meyer review. So what is post-cure care? It involves obviously primary HCV prevention, which we already talked about. So in conclusion, primary prevention of HCV infection is effective. We've seen that, and it's a combination strategy that gets used. There's also effective secondary and tertiary prevention interventions that can be offered to people that help with getting people diagnosed, linked to care. These tend to be multidisciplinary, integrated, community-based, involve care coordination. Documenting the real-world effectiveness of these drugs, these DAAs, requires a focus on HCV care as well as the other care and prevention needs of people who inject drugs. And I think that's something we cannot forget. It will involve the expansion and use of the full range of harm reduction services, primary prevention, HCV care engagement, and prevention of reinfection. This is echoed in the paper by Grappoli and colleagues as well, and that strategies need to integrate into existing foundations for prevention for this population. Challenges examining adapted and proven interventions for DAAs going forward, being really clear and consistent around the operational definitions of care, linkage to care, and pre-treatment evaluation, and treatment adherence, and what these things are and how we define them. We need comparative and rigorous research of multi-component models of care for HCV in this population. And we need to continue to make use of the evidence-based treatments that we already have for substance use disorders and integrate them, but we also have to push for advances in substance use disorder treatments. And then a better understanding of the specific and direct effects of substance use disorder treatments on HCV clinical outcomes and vice versa has been rarely explored and could be a very interesting line of research. Some references, and thank you.
Any quick questions for Dr. Cox? Quick questions and quick answers? No. Maybe for the sake of time, we'll move on.